Hello and welcome. My name is Andra Stancu, Project Officer with the International Federation on Aging, or IFA, and it is my great pleasure to welcome you to this town hall, Biosimilars in Ophthalmology. What do patients and their families need to know? IFA acknowledges the support of Bayer to convene this town hall through an unrestricted educational grant. Throughout this meeting, we welcome you to exchange thoughts, questions, and resources in the chat box. And please note that this video recording will be made available on the IFA's EyeSeeYou webpage, which will be shared shortly in the chat box. Vision health is intrinsically linked to independence, functional ability, and quality of life. However, the burden of blinding eye diseases is significant and growing alongside a growing older aging population. The World Health Organization's World Report on Vision estimates there are about 342 million people globally affected by blinding eye diseases, such as age-related macular degeneration and diabetic retinopathy. Innovations have provided treatments that can now slow the progression of these conditions, and a recent report from the Conference Board of Canada estimates there were over 650,000 ophthalmic interventions in 2020, and nearly 1 million are projected by 2040. While the demand for effective and appropriate ophthalmology treatments is strong, Canadians are disadvantaged when they are not fully informed and empowered to participate in decision-making about their vision health. Biosimilars are emerging medicines that may offer an alternative to some current ophthalmology treatments. However, there are significant knowledge gaps among Canadians with vision loss, their caregivers, and even health professionals about their appropriate uses. This town hall offers a critical opportunity to explore challenges that exist in sourcing evidence-based information about emerging therapeutics and inform the way forward for biosimilars in ophthalmology in Canada, centered around the needs of patients. I am now honored to introduce the moderator of this town hall, Mr. Jim Tokos, the National Vice President for the Canadian Council of the Blind. He joined the CCB in 1997 after suffering vision loss while employed in a senior management position for a large North American corporation. Once completing rehabilitation and losing most of his vision through a condition called angoid streaks, Mr. Tokos found himself looking for an organization which challenged his new boundaries and hence joined the council. Jim became local president, was elected to divisional president, and was appointed to the National Board of Directors, and in 2008 was elected to the National Board. In 2010, Jim was appointed to first vice president, taking on many important management positions within the council, including vice president in charge of finance, active member of the advocacy committee, chair of the membership committee, and Canadian delegate to the World Blind Union. And since 2008 has attended 3 general assemblies. So for his vast knowledge of Canada's vision health landscape and as a longtime colleague of the IFA, we are so grateful to you for leading this important discussion. The floor is yours, Jim.
Thank you very much for your kind introduction, Andra. It's always nice to be involved with the IFA and the resurrection of the EyeSeeYou program. And what a wonderful segue into the discussion we'll be having this afternoon. So yeah, I think the objectives and takeaways that we want to have is today, or what we want to discuss is, so the biosimilars seem to be moving into to Canada quite quickly. They've taken a large part of the oncology space, and as well as has been adapted quite quickly into the arthritis space. So I guess now that they've had success in moving it along, it's now being introduced into the ophthalmic stage, and so we as a patient organization, and IFA, as far as seniors who are suffering or maybe suffering in the future from different eye diseases, we want to make sure that the efficacy is first and foremost for the patients. And we, in doing so, have always preached to our members and the group and the organization that we represent that that they ensure that they get fully informed consent, making sure everything is approved by Health Canada before they sign on the dotted line. Now, that has been a problem in Canada for the last few years, is that the provincial landscape is just switched all the time. And so it seems like a never-ending roller coaster ride for us to advocate in different provinces around the country. So we want to try and ensure that we come up with some kind of basis that we can go to our members and IFA people with, where we can acknowledge the fact that the landscape across Canada is going to be the same. All the drugs, or all the biosimilars or biologics are going to be Health Canada approved, and it's very important for them to know the questions that they should be asking their ophthalmologist when they have an appointment after suffering the eye disease.
So at this time, we would like to jump into the kind of moderated discussion, beginning with speaker remarks. And our first speaker today, we're very happy to invite Mr. Barratt Hickling. Mr. Barratt Hickling was born and raised in Barrie, Ontario. He is 64 years of age, married with 2 children and a granddaughter. Brad is a retired tool and die maker and worked in industrial automation, building machinery, and integrated robotics for 42 years. His interests are golfing, fishing, and maple syrup. Now, Brad was diagnosed with, I'm going to have trouble saying it, but it's a chronic inflammatory disease which affects the joints along the spine. Infusions with an originator biologic medicine began in 2010, after which Brad was switched to a biosimilar in 2017. Brad shares with us in this town hall his experiences with the process of switching from a biologic to biosimilar medicines and the critical elements within his transition that helped him manage his chronic disease and also continue to do the things that he values. So, Brad, over to you.
Okay. So basically what happened was, once we made the decision that I was going to switch to the biosimilar, I can go through those points of why we did it if you want. So
Please.
Basically, okay. So basically what happened was, my rheumatologist and I, he saw this biosimilar was on the way in. So he suggested, because of my great success with the biologic that I was on, that it would be maybe a good idea, if I was okay with it, to try switching. There was 4 basic things that helped me to make that decision. The first one was the trust that I had in my rheumatologist and his team. The other really important was that it was guaranteed that I would be able to go back on the real biologic if this one did not work. Obviously, another thing that helped me was the insurance. It's cheaper. The biosimilar is almost half the price. And I guess the other thing, if you want to think about it, was, say this had have happened 1 year after I had my great success with the biologic, I probably would not have switched. But because it was 7 years of basically pain-free, I thought I would give it a shot. And anyway, it was all good. Everything, there was not one difference whatsoever so far. And I've been on it now for 3 years. The other thing is talking about the transition. So basically what happened was when we made the decision to do it, it was basically seamless for me. My rheumatologist and his team took it over. They, the first thing that, once I signed my name, the first thing that happened was I got contacted with an email from the infusion clinic that was going to give me the biosimilar. And that was it. I got a year's full of appointments, and it was a new clinic, which was no big deal. And I would imagine that they looked after telling the first biologic that I was getting, that team, that I was no longer going to be coming. So for me, it was no problem. It was basically simple.
That's a very interesting story, and hopefully we can assume that kind of thing is going to happen in the ophthalmic world as far as switching. But what do you think are important questions that the patient practitioner should be asking when switching is going to occur? What are the most important questions that you feel?
Well, my most important question, and probably what made me go ahead and do it, and I don't know if this is true in all aspects, but I was guaranteed that I would be able to go back on the biologic that I started on. That was a miracle for me. Mm-hmm. So that was actually my question. I did ask that question.
Right.
And I'm not sure what else I can add. I mean, the fact that it was half the cost was part of the decision making, but I don't know if that can still happen, if it can still be guaranteed that you could go back on the original. Maybe you can't, I don't know. And if that was the case, I might not have changed.
Well, in our patients, we have had the fact that they've had the options given to them that they can always go back, but in a lot of cases that can be damaging. So, there's more and more questions that have to be asked.
Yes, no, that's another question. Okay, you just reminded me. So basically, when we were thinking about it, I asked if I could go back on, and then I also asked, would that still work for me? Mm-hmm. And I was told that it would if I went back on the original one. So.
No, and that's a very good observation, and I love your term guarantees.
Oh yeah, I know that, but I don't know what other word to put in there.
No, and that's that's pretty decisive, and I think that if and we hope that people that are involved in switching with the biologics in the injections that they're getting in their eyes, and because currently there's new drugs that are coming out all the time into the biologic field, and so we're getting into drugs now that are in front of Health Canada or have recently been passed by Health Canada that reduces the amount of injections. So when you're dealing with the eyes, anything that reduces the amount of injections that you have to get is healthy and improves the efficacy of the injection. So going into the biosimilar world, again, it's following on what you've said and the wonderful story you've had.
Yeah.
So because it's of a lower price, and we want to make sure that people are asking those kind of questions. Can we go back? Is it safe for me to? What is the difference between a biologic and a biosimilar? And these are all the questions that I'm sure that you had to ask as well. And
Yeah,
sorry.
There was one other thing, was that exactly what you're saying. There are so many new ones coming up and coming, new ones. I probably would have had 2 or 3 or 4 more options if I had gone on this and it didn't work and I couldn't go back on my original. There's more and more options out there now, which is comforting to know.
Right.
And certainly, if I may intervene, having the options is really important, but also important is to be able to access them and to have the ability to make the choices based around your needs, and to do that in consultation with your provider. And I think that these differences across provinces are quite starking, because there are some differences in the types of policies and whether you are forced to switch or whether there are alternative policies being implemented. This does differ by province.
Yes.
And so if I may, if we'd like to move to introducing Ms. Tambyn Watts, who is the second speaker in today's town hall. And it's really an honor to have you with us, Laura. You provide such a force in your speaking and in all of your interventions with the IFA, as a lawyer, advocate, researcher, and media commentator from CanAge. And so I invite you to share your remarks as we move forward with your intervention. And please unmute.
Yep. Thank you so much for inviting me. I'm going to keep actually the screen in this presenter view, which is a little unconventional, but I find it handy to remember what's coming next as well. So I'm so delighted to be here today. You see I'm wearing my glasses, and vision is a critically important issue, as I see so many of my other colleagues are. I'm so grateful for the opportunity to learn from you. And Brad, I just want to start by thanking you for sharing your lived experience. So important always to start by hearing from people who are having their own knowledge through their own journey. And so thank you so much for sharing that with us today. Just a quick who we are. So we are a national seniors advocacy organization called CanAge, and we're looking to support the rights and well-beings of older people in Canada. We work globally. We're a proud member of the IFA, and we're always so grateful for your leadership at the IFA. Thank you, Jane. Thank you, Andra, for your work and your championing of this critically important issue. I want to also just flag a couple of my team members who are on the call today. Lisa Hartford, who has a wonderful experience and used to in fact work as well at the CNIB, and Sean Fitch as well. So if you see their names, they're part of our CanAge team. I wanted to share with you as a top line how critically important we believe vision and sensory health is. We created what we call the Voices of Canada's Seniors, a roadmap to an age-inclusive Canada. And in that process of 5 months with about 20 people working 24 hours a day, we were able to build a national plan for aging for Canada that's evidence-based and also allows for organizations, governments, individual seniors and community groups, as well as private sector to come together and find prioritization and directionality. we specifically included sensory health, and within our sensory health, specifically included recommendations, which you can see here on the screen, for increased funding and patient choice for cataracts, glaucoma, diabetic retinopathy, macular degeneration, and other eye-related healthcare needs, that they be made available and that they be prioritized. We are looking to make sure that we can preserve eyesight and prevent vision loss. And you see here some of the other aspects to that that we've called out as well, including increasing treatment options, reducing wait times, and allowing faster access to innovations. And, biosimilars are part of that conversation, and one that we think that many people don't know enough about. So in the course of my presentation today, I'm going to start off by telling you what I want you to take away. It's the teacher in me. So we have 3 key issues that we want to highlight in the comments. The first is we want to emphasize the importance of all of us being part of the conversation together to influence policy. And that's why discussions hosted by the IFA and others are critically important. CanAge is directly a part of influencing policy and creating opportunities to raise awareness with government around prioritizing of funding. So we just want to say that we think that we have to have that both holistically as a group, and again, starting off with Brad and speaking of his lived experience, needs to inform our broader policy change discussions. We also, as a second point, we need to encourage not just the medical focused professionals like folks in ophthalmology and others. We need to encourage them to move more quickly to understand that biosimilars is not something that's just going to sit on the shelf. It's not going to happen to us, but we need to actually engage vision professionals to become involved in the conversation in Canada. And we also want to prioritize, and this is a key point of my discussion today, how much more information and education and awareness that we need in Canada so that we can really help to shape the discussion and get ahead of the curve, not wait till things happen to us. And certainly when Brad was talking about his experience, we were talking about the fact that some people know some things, but many people don't know a lot around these issues. And one of the pieces that we also wanted to flag in the course is that people often don't have a good understanding between what's a biosimilar versus a biologic, or how are biosimilars the same or different than generics. Like, we have all of these words that are very jargon-esque, and we don't have a lot of understanding what they mean at the best of times. So I thought it might be helpful, I hope, to just give you a little bit of an overview from our point of view where the narrative discussion exists. So biologic treatments, starting when we're thinking about where they're developing, 2009, we start seeing them for within more of the inflammatory arthritis stage. And we see from the research and excellent evidence, and I might add some great reports done by the IFA, that there was significant knowledge and uptake within the inflammatory condition space. And we can tie that as well to the wide campaigning around education, both targeted and broad spread, within both the healthcare provider sector as well as the caregiver and patient sector. So one of the learnings out of the uptake within the inflammatory arthritis for biologic treatments is that people did have to understand what they were. They needed to be able to weigh out the risks and benefits, and they needed to be able to feel comfortable that their patient choice was going to be respected. Patient choice is something you're going to hear me talk a little bit more about that today, because that's certainly a key component to our conversation, particularly seeing some of the forced switch concerns happening in our Western provinces, which is a key piece of it. Some of the early side effects were a little bit concerning, but patient populations work very well when they had enough information. And we certainly heard as well that patient choice is critical. And when we're talking about quality of life, really understanding that lived value of the person for whom the healthcare choice needs to be made. So it's not happening to the, I'm going to use the term patient, which is I mean that within the medical scenario, but the person for whom is having the condition, we really believe that the patient choice is important, and you can't make a choice unless you can have the information to make the decision. And that's not just good practice, that's actually the law across Canada around healthcare consent. You need to be able to have the information, weigh the options, have a chance to ask questions and receive answers, weigh out the costs and benefits, and then only then can you actually provide a consent. In my respectful view, we do not have enough information in Canada broadly for most people to really have a good informed consent. So I want to flag that again as a piece I think that's missing. So we know the biosimilars are approved in Canada. They've been found in many cases to be safe and effective. They're particularly, now we're having this conversation around retinal disease management. And we certainly understand, and we're a seniors advocacy group, that it particularly affects, but doesn't only affect, but particularly affects many of our older adult populations. And so certainly we care about, aging across the life course, but when we're looking at questions, for instance, for macular degeneration, certainly age is a key factor in that. Questions about what does that look like? What do the words mean? If I just said a biologic is going to be here, it's going to be injected into your eye, you're going to have this done every 4 to 8 weeks, and you may need to actually go to a particular location and have a particular team to particularly support your treatment. That is a really important piece of knowledge to understand, is that where the location of treatments is provided in Canada may, in some instances, be tied to the physical location and the care team that you are engaging with. So in the biosimilar, you may have a different type of a patient experience. It might be injected into your eye, for instance, every 8 to 12 weeks. And whether or not you get that type of client experience with the same team or in the same location is a change. So it's not just about whether I'm taking 2 different kinds of the same thing. Am I taking a generic, for instance, like a Tylenol or an acetaminophen? It is actually not just a different experience in terms of how the treatment option may be provided medically, but it actually may be different as well, how it's provided in terms of the physical location and the care providers that might be providing it. And that's something that we don't know enough about as well. And it may play a huge role in our understanding about patient choice. So what's the patient experience like? We certainly know that there have been a number of concerns that have been expressed. We flag here, Dr. Janet Pope and in some of her work on this area. And in one of the quotations that we pulled out is, in general, patients have already failed many treatments prior to being on a current biologic. So they may want to remain on the same drug and not rock the boat. So, what we're seeing here again, from this professor of medicine and rheumatology, is that many patients on biologic resist transitioning to a biosimilar. She notes that in general, patients may have already failed the number of treatments. And so by the time you find something that works for you, there may be a great reticence to changing the thing that works. And what I would offer is, our understanding is that there may be increased concerns about being forced to it. So that narrative around being forced to do something versus having patient choice, I think, is a critical issue. Canada typically adopts new treatments later than other nations, but that's not been the case in this area. One of the reasons we've been slow to onboard biosimilars for treatments of eye disease, what did I say earlier? I meant later. So Canada is a lagging country, my apologies. And so if you're looking at kind of globally, you'll see that, for instance, in the EU, they're far ahead of us in terms of adopting in this particular area, but also you may find that in other circumstances. So Canada tends to be a little bit more slow and perhaps a little bit more hesitant. And our outlining of our platform talks about the fact that we need to do better in being both a bit more responsive and a bit more rapid, and not just waiting to see for no good reason. And I'm not saying we shouldn't wait to see for excellent evidence. Evidence, of course, is critically important to the conversation. But what we don't want to do is have excellent evidence and then wait. And boy, that's never been the case more clear than in the time of the COVID-19 vaccine, where I think that we don't want to see a long lag between, good evidence and good uptake. And I think we need to have that same framework in Canada. So I just wanted to share for you where are the biosimilar hotspots in Canada. And this gives you a bit of an example visually here. So you see that, there's a big uptick in Europe and in the kind of regions around non-EU, your EA Europe, you'll see the differential impacts. And, in Canada, you see the number 15 is pretty small here. And so this is the count of biosimilars launched based on the molecule name, but not the brand name. So I just want to share with you that this just gives you a sense of where the conversations are. And you can certainly see Canada is a much more limited dispersion in that. But so how important is it? Right now, obviously, we're competing for dollars and we're competing for attention. Where does this fall? It's not COVID, so is it important? That's the question everyone is asking about everything that's COVID. So how important is this conversation in the dollars and attention of Canadians? Well, it's very important. First of all, vision loss has a huge impact. Fighting Blindness Canada speaks about the cost of inherited retinal disease at $1.5 billion. And we just also want to raise that the cost is often borne by families and patients. So it's a very costly type of healthcare issue in terms of impact. We also at CanAge are trying really to focus on the question of age barriers. And this is certainly one of those issues where age is a differential impact. Canada does not have a pharmacare system, and we're one of the few in our comparative jurisdictions that we look to globally that does not have a pharmacare system. But if pharmacare is coming, and certainly COVID-19 may have an impact on our ability to onboard pharmacare, we're going to have this conversation before the conversation about rollout of pharmacare. We need as a sector to be ready to understand what it means in this area. So we're going to need to be able to be much more nimble and much more able to wrestle with this question in an informed way. I also just want to bring to bear that we need, again, to make sure that people understand the cost of retinal disease within the context of an aging population. So the numbers that we have right now are going to go up significantly as our population is aging. So when we're thinking about, the 65-year-old person now, they may not be experiencing retinal disease, but the chances that many, many more of those will experience these types of significant health inputs for their eyesight is increased sharply. So when we're looking at it, I think also need to look at it with an age inclusive lens to make sure that we're preparing now for what's happening in our aging population. So we know that Canadian seniors will represent about 25% of the population by about 2031. And access to vision health and treatments is going to be critically important to maintain optimal health and wellness. We know the intersection between eyesight and dementia. We know the intersection between eyesight and falls prevention. We know the difference in terms of social engagement, loneliness, and the ability to engage in transportation options. So when we're thinking of vision health and we're thinking about the narratives of things like treatment options, we need to not only understand it from a medical point of view, but also from a psychosocial point of view and a community connected point of view. So it's our hope at CanAge that we engage much more fully in conversations about biosimilars as treatments for vision loss, that we hope that we can learn more about their benefits and that we can see that a variety of treatments should be made available for people to engage more fully in their vibrant and purposeful lives as we age. So we know that older adults are marginalized for a wide variety of reasons, but we hope that preventable loss of eyesight should not be one of those areas of marginalization. If you'd like to learn more about the work that we're doing, and I'm of course happy to share this information, you will see our questions detailing recommendations on vision loss and our Voices of Canada Seniors platform under O for optimal health and well-being. And you'll find sensory is the first of those issues. So I really want to thank you for the opportunity to speak with you today and to learn from you. And again, we need to be part of this conversation for influencing policies. We cannot let just medical care come at us in a fluid way. We need to be active in discussing this at the policy level. We need to engage with patient groups and users and people with integrated health experiences with the eye health community to help them better understand what these issues are. And above all, please do not think that people understand this at all. They absolutely don't. But they would understand it better if we spend a little bit of time, effort, money, and engagement around making sure that folks have the information they need for best-in-class patient choice. Thanks very much.
Thanks, Ms. Tamblyn-Watts. I really appreciate the work that you've done and the insight that you have. We have a lot of the same questions in the vision loss community. And one thing I would like to ask, how can we, in Canada, as you know, we're talking about Health Canada Approves. And, when we first got involved in the EyeSeeYou program many years ago, it was because there's 12 sectors in Canada. So if you could give some insight on how we can get the provinces all on board to make sure that this information is provided, so that everybody has a good understanding of biosimilars compared to biologics, et cetera. Because right now there's a couple of provinces that are right into it. We understand. And, we as Ontario are waiting until this COVID situation is over before we make any decisions. So, as the conversation continues, how can we try and manifest this as we're a patient organization across Canada as well? So we represent the 12 provinces and territories. So how can we kind of put this conversation into a clump to be inclusive?
Thanks so much for the question, Jim. One of the reasons that we created this roadmap for an age-inclusive Canada was to be able to create kind of a common platform so that we could have these discussions around, and also to be able to understand that they navigate not in a one discrete area, but to see that within health and well-being, that sensory issues are there, and that health also includes things like eye health, but then to expand that and have those conversations about the impacts of social engagement, the impacts of vulnerability and social. So that's why we created the roadmap, and very specifically, and I might add with the leadership and advocacy of the IFA in our learnings, included these particular areas. So we have found that when presenting our roadmap and letting people choose and pick areas of their own key advocacy, that it's very helpful to have this kind of common language document.
Right.
I think at a governmental level, really important to make sure that people understand the issue of health equity. And that's a jargony term that I'm using amongst us. But for the everyday person, if I live on one side of the street in Ontario and I look over to the other side of the street in Manitoba, do I have a completely different experience when it comes to eye health? And the answer would be yes, that's probably what's actually going to be right now.
So true.
I think as well that people need to understand the reticence of folks around being pushed into switching without adequate information. Again, the lawyer in me goes back to the idea of healthcare consent. And healthcare consent means you have to have enough information and be able to, weigh out the risks and receive the benefits. And I think it's a rare instance, I'm not saying never, but I think it's a rare instance that people have enough really good information. The research that we have seen really has said that, patients, and again, I'm using that word, patients often are relying on their healthcare providers to kind of make the decision for them, or alternatively, their decision is being pushed on them by some new government initiatives. And at CanAge, we're very concerned about making sure that, patients and just anybody has enough good information, and that where patient choice is available and client best-in-class practices should be at the forefront. So how can we do it? I think it's important to have a document, but I think it's important to have a principles and integrated approach too.
Thank you.
Thank you so much. If I may, we have a couple of questions here and comments as well in the chat box. I would like to call on Kathy as well as Lisa Hartford. So if you can both ask your questions or just reiterate your comments to add to the discussion, please. Kathy, we'll start with you.
Okay, well, this is interesting. As some of the IFA people know, we're beginning to work on somewhat parallel issues on hearing. And the WHO is poised to launch the World Report on Hearing. So I signed on to learn, and I have a lot to learn, but I get the feeling that there are a lot of parallels. And in our work using the Canadian Longitudinal Study on Aging, our group, which is researchers in a sensory cognitive team on Canadian Consortium on Neurodegeneration and Aging, we have always published hearing, vision, and dual sensory. And by the time, Canadians get to 85, 50% of them have some dual sensory loss, vision and hearing. So it kind of seems like we should join forces. And I know, Laura, you said sensory, but you only spoke about vision. So I'm kind of hoping you really mean sensory in the broad sense of sensory.
Thanks for the question. I certainly, and I'm so grateful for the work that you've been doing, Kathy. It's really just been wonderful leadership. I thought it would be helpful just to show you the 6 compass points and what it looks like in our interactive map. And so as we're talking about, our O, optimal health and well-being, you'll see the issue number 6 is sensory health. And then I just wanted to share with you that we have very specific recommendations about eyesight, hearing, oral, touch, and actually we got feet in there as well. We couldn't really figure out how feet was a sense, but there you go. We went with it. We figured it was part of touch. So I did just want to share with you that we think of it as an integrated approach.
So much, Laura. And so I did see a comment from Lisa. And then afterwards, we do have a comment a question for Brad. So I would invite Jane to intervene after Lisa, please.
Perhaps if I can.
Sure.
Okay. Yeah. Hi, Brad. Jane Barratt.
Hi.
Thank you very much for your discussion. I think it's really important to hear from the patient. I think I can wax lyrical around what it's like, but I don't know. And what I heard from you were a couple of things, and I wanted to see whether you could expand on it a little bit. One of the things is that there was a guarantee, right? But it seemed to me that you had a trusting relationship with your doctor. There was something unique about this relationship over a period of time that was important, and they respected your views, in the whole decision-making process. So I think that was one of the things that I heard. And I'm trying to think of what are the principles that we can bed down if we're actually starting to talk to patients and families about this. What are the 10 key areas that you will need to talk with your doctor about? So I think that was one of them. The other one, Brad, was, you know, you talked about, you talked with me about, you know, all of the administration stuff was done for you. So it was very much a patient-centered process. So you didn't have to worry about changing the tires and getting the oil in the engine, and that all you had to do was arrive. I think that's another thing. I think the third thing for me was, you know, the dramatic description that you shared with me about pre-treatment with a biologic, and the fact that when you switched to the biosimilar, that there was absolutely no change. So I'm just trying to see if we can pull out some of the principles that, you know, we could start developing for patients and their families. And I guess the other point was, you know, your family. You know, where did they fit into the conversation? So perhaps you could talk about that a little bit.
Yeah, actually, I don't know. There, I guess, lots of people that have arthritis, and I have ankylosing spondylitis, so it's basically was starting to fuse my backbone. But the pain and stuff I went through, I'm sure there's lots of people that are going through it or have, and it was very tough on my family too. It was super tough on me, obviously, but after going through all of the medications and all the stuff, that it never really did work for me. I got a little bit of relief from a few things that they took off the market, and the day I went in and I said, I'm ready for we've been reading about, it's Remicade, about the biologic, and they got things rolling. And as soon as I got my infusion, I woke up the next morning. Basically, I figured I was cured. It was like a miracle, really, for me. So as time went on, everything was good. I was normal at that point. How old was I? You know, everything was good. Golfing, working, you know, doing everything I wanted to do. And then once the suggestion came from my rheumatologist, it was like, this guy is the guy that basically saved my life. So yeah, let's do whatever you think is fair. Let's do it. But I mean, there was still that thing, and you can't use guarantee, I know, but he was very positive about the fact that I could go back on the biologic I was on, and that it would work. But yeah, the transition was seamless. Like you say, they looked after everything for me. And I was a little nervous, obviously, but you know, things just carried on exactly the way that my originator was. There was no different symptoms or anything. It was straight through.
I think one of the challenges, that's really helpful, Brad. I think one of the challenges that IFA and others are experiencing is to encourage ophthalmologists to be excited that biosimilars are coming down the train track at us. Excited as in, you know, please join with us in learning and being advocates so that we can be at the forefront of policy change, because we do need, you know, the clinicians to be with us in this conversation before, you know, policies are made. It's difficult to actually change policies. It's much easier to get out in front to help to influence. So I think that's one of the areas that, you know, that we're, I wouldn't say struggling, but we need to be driving, you know, a little bit harder. And it seems as though your rheumatologist knew exactly, you know, what he needed to to actually have that conversation with you.
Yeah, it was, he's been great for me. The whole team, there's a whole team, my nurse and the rheumatologist have been, I'm a very lucky man.
Well, look, you shared your good fortune with us, so we thank you for that. But I wonder, Andra, can I
My
take the liberty of just asking Jim for a minute? You know, I wonder whether we really do need to join forces and write some letters to some ophthalmologists to encourage them to have a conversation with us about this. I think we need to, you know, step forward. What do you think, Kathy, Jim?
No, I do. I think so as well. And man, if we could get, if we could clone some of them to this success story that that Brad has shared, that it's so encouraging. You know, I give you a lot of credit because you know, you had faith in your doctor and your rheumatologist, and that's the kind of bedside manners that, you know, we're always looking for and hoping that we get. But unfortunately, like you say, Jane, we don't always get that. So yes, I think we have to, you know, get on everybody on the same page and push it forward so that, you know, the ophthalmologists as well are aware of, you know, what requirements they have in this, in the context of the conversation.
I have a follow-up question for you, Brad, from Kathy, from Professor Pichora-Fuller. Please.
Hi, Brad. So I
Hi.
don't really know anything about your treatment. And it sounds great that you felt like you were almost instantly cured, but what actually changed for you? You know, so what made a difference? What practically in your life made a difference? I guess your
Okay.
vision improved as well as
No, it's no, basically my condition is ankylosing spondylitis. So it's a inflammatory arthritis of the spine. So the pain is overwhelming. Both my SI joints, I couldn't walk. I was basically crawling to the dinner table. My life was just, it was awful. It was awful. And so what changed with me was all my pain was gone. I like all the different joints and sore, aching things were gone in one day.
So how does that, I'm trying to understand if does this connect to vision?
No, basically what they asked me to speak about was the fact that I changed from original biologic to a biosimilar,
Okay.
and it made no change to me.
The essence is really taking kind of the good practices and carrying them over into the emerging field of ophthalmology. Because as the biosimilars do start to emerge, you know, the implementation of the policies must be informed by the patient perspective and be patient-centered in order to maximize their value. And so I think I might hand the floor back to Mr. Tokos as our moderator here. Any kind of takeaway messages or questions for today's town hall?
I think some of the, excuse me, some of the takeaways are, you know, the fully informed consent. And, you know, I think that, like Jane said, we have to get ahead of this. And if they're coming into Canada, we know they're coming into Canada. So like Jane said, ophthalmologists should be enthused by this and having these great forward conversations with their patients. And I think that's going to be key. You know, as you know, we continue to struggle with COVID-19. I think this the other part is that we have to make sure that we continue to look after our eyes, and hospitals are open. So although people are being told to stay at home, please, continue your treatments and make sure that any doctor's appointments you keep, because if you don't, you can do far more damage to your eyes.
Thank you so much. I will also call on Barratt and Laura for a couple of your takeaway messages. And if I may just provide a little bit of I guess, my summary as well of what, is important to carry forward in this discourse. The IFA is particularly, based on our work in this field, we're certainly concerned about policies being patient-centered, about being effective and appropriate for the patients. And safety is a big part of that. Having the access to, the most appropriate medicine for you is a big part of that as well. And so, from Brad, we did hear about the importance of having that support, having that informed conversation with a trusted health provider, and having your family to support you, and knowing, kind of having, not a guarantee necessarily, but knowing what the expected outcomes are, and having that option to make exceptions, to switch back to your original therapy if needed. Those were certainly important things for you. And Laura, just going back to that wonderful resource that you shared, thank you so much. Just summarizing kind of the roadmap that is certainly a great kind of framework to advocate for recognizing the importance of these sensory issues and how we can best advocate to have them elevated on the Canadian stage. So Brad and Laura, can I ask you for just a couple of your takeaway messages?
Well, maybe I'll speak first. So Brad, you can speak last, because I think it's really important to have your experience maybe open and close, if that's okay. I've put here just in the chat, you can download the PDF, you'll see it here, and also the link is on our website as well. And we certainly want to emphasize the importance around patient choice, but patient choice can't happen without patient education. Patient education can't happen unless we have allied health professionals, including ophthalmologists, starting to think and know about this. So we're excited to be part of this conversation. I think that we've got a long way to go to get people to understand the basics. CanAge believes, sensory health, integrated sensory health is really important, and really looks forward to working with other colleagues on this call and other organizations to bring forward the needs around sensory health. We certainly understand the impact about vision health in specific, and we want to make sure that we're well placed in Canada to take advantage of innovative technologies and innovative solutions as they become available, to reduce the lag time between approval and uptake, but also to understand and respect the fact that best in class, may be for some a little bit different from others, and that we need to make sure that what's available matches what is desirable. So thank you again for being part of this. We really look forward to continuing this conversation and welcome any other impacts or thoughts that we can work together on.
I just like to say thanks for having me on, and I hope that I was able to help somebody make a decision, or this isn't really my forte, speaking. So yeah, I just hope that I could help in any way. Anyway, thanks.
And we thank you. It was, it's, as all of our, everyone on the call can appreciate, your lived experience is essential to this conversation. And we need to carry that into, the ophthalmology space as well. And if I, as we head into the close of this town hall, as you may have noticed, the IFA has announced as part of the 15th Global Conference on Aging, Rights Matter. We will be hosting a presidential symposium on vision health on the 11th of November next year, 2021. So this will be certainly an opportunity to continue this conversation, and hopefully we will have a lot more evidence-based conversations at that point. And we are delighted to welcome you alongside foremost thought leaders in discussing new knowledge on coordinated care and treatment, emerging policy issues on biosimilars and ophthalmology, challenging consequences of end organ damage, and the role of civil society on improved care outcomes from both vision and a functional perspective. And so we certainly welcome you to the conference, to that conversation. And on behalf of IFA, we're so delighted to have such wonderful speakers with us and participants on the call. Thank you, Jim, Brad, Laura, Kathy, Bruce. I see your video is on. Welcome. And thank you so much to Dr. Jane Barratt, IFA Secretary General, for the tremendous support. And once again, thank you to Bayer for their support of this initiative through an unrestricted educational grant. And so with that, we look forward to being in conversation with you, as this discourse continues. Thank you very much.
Thank you very much.
Thank you.
Bye.
Thanks, everyone.
Thank you.
Bye.